Good morning. The Cloud CME activity code for today's grand rounds is 1535. Our speaker today is Dr. Jabraan Pasha. Our program is underwritten by an educational grant through OSU Medical Center, Graduate Medical Education. A disclosure statement has been signed and is on file in the Graduate Medical Education Office. Dr. Jabraan Pasha is a native of Tulsa, Oklahoma. He received his medical degree from the University of Kansas School of Medicine and completed his internal medicine residency at Mayo Clinic, Arizona. Dr. Pasha is an associate professor in the Department of Internal Medicine at OU Health Physicians and the assistant dean of student affairs at the OU School of Medicine here in Tulsa. He also serves as the president of the Tulsa American Heart Association. One of Dr. Pasha's major academic interests is the impact of implicit bias on patient care and society. He has presented Unlocking Implicit Bias over 120 times, including sessions for the American Association of Medical Colleges, Medical Clinic, Mayo Clinic, and internationally in Paris, France, Portugal, and Ottawa, Canada. I've had the honor of collaborating and working with Dr. Pasha on several occasions. He is kind, compassionate, and leads with a servant's heart. Please welcome, as the next voice you will hear is Dr. Jabraan Pasha. Thank you.
Thank you, Brenda, for a nice introduction and for helping facilitate this session. Good morning, everyone. I'm not a morning person, so I'm always impressed when I see 60 plus people at a 7 o'clock grand round. So I really appreciate you all being here. I just I was looking at the list here. I started to think about how unique medicine is. It seems especially academic medicine. The longer you are in academic medicine, this is my 9th year out of residency, the smaller the medical community seems to get. And I'm just kind of looking through the names. I see Dr. McNeil, Dr. Coffey, Dr. Sam, Dr. Koshi, people that I've met along the way in various roles and situations. And it's just nice to feel connected to medicine, especially after all we've been through in the last few years. So thank you all for being here. I'm gonna share my screen and just kind of talk about what this session is going to be about. I think the best way that I could kind of introduce it is to say that it's part of a larger conversation about what shapes health, right? We're going to talk mostly about implicit bias and what it is, where does it come from, how to mitigate it, but really, the overarching really conversation that I hope that this generates is this question here, right? What determines health? And I think what we're starting to do now at least in medicine, and hopefully the rest of the world comes around, is understand that health really isn't what we've always thought it to be, right? We are now recognizing that health happens really early in life. It's more about the opportunity to be healthy. And we're knowing now that health is driven much less by the healthcare that someone receives or the healthcare that we deliver as healthcare workers than it is about the social environment that people are faced with. And within this conversation of the social determinants of health, we have the conversation that we're going to have this morning, which really settles in on the social and community context. I don't know what my overall goal is in life and in healthcare. I know it's changed, and I hope that it is starting to help bring other people along to recognize that, we have a role as physicians. A lot of us are physicians on the call, but we're all in healthcare in some way. We all have a role in terms of delivering healthcare and help helping healthcare be more accessible. But I hope that we can start to recognize that true health probably happens well before someone goes to the doctor's office, right? It really has to do with the opportunities they have or the opportunities that they don't have. And that results in education deficits for some communities. It results in income, socioeconomic deficits in communities. It results in certain neighborhoods being unsafe and unhealthy and riddled with crime. And, I think of crime as a symptom of poverty, right? And we know that all of these things impact health in a significant way. And I hope that as the leaders in community health, we can really start to drive this narrative and help shape policy, right? Because all of these social determinants are ultimately driven by the policies that civic servants help generate. So that's the bigger discussion. Today, the smaller discussion is about implicit bias, and that fits in this social community context. And so we're going to talk about what implicit bias is. And, I think I always have goals and objectives, right? That's a part of any talk you give. And these are the three kind of major objectives that I'd hope to achieve in, the short 45 minutes that I have with you all. But the big picture goal is to help continue what I try to do every single time I have these conversations, is to destigmatize what it means to have implicit bias. And what I mean by that is helping us all understand that when we talk about implicit bias, it's not to make anyone feel ashamed or guilty, because we shouldn't feel ashamed or guilty about it, because we all have it. It's part of being human. It's part of the human experience that creates these biases. There's no way around them, right? So why would we need to be felt ashamed or guilty about it? And I think it's a big misunderstanding that's going on now more than anywhere. If you've watched even the national news, especially the local news, there's just a misunderstanding of what implicit bias is and what we are trying to achieve with these conversations. And so I hope if it's not clear what that this conversation really should be like, I hope it is clear after the time we get to spend with each other this morning. So this is more housekeeping than anything else. Implicit bias goes by other names as well. And I just want to make sure that we're all aware of that. So you may hear the term unconscious bias, right? Just about as much as you'll hear the term implicit bias. I have just, for whatever reason, settled on implicit bias, but you also hear the term unconscious bias, and fancier folks than myself use the term implicit social cognition, which, I think all in all of these terms are relatively interchangeable. I think there's some nuances, but for the purposes of our discussion, the discussions that I have, we can kind of think of them as the same, one and the same. And essentially what we're talking about is when we have attitudes, stereotypes, associations even that are able to impact our understanding, our actions, and our decisions in an unconscious manner. It all happens subconsciously, right? So I should possibly bold and highlight and underline the term unconscious, because that's where the money's at. That's why this is a whole thing. And that's also why this concept is really difficult for some people to come to terms with, to even believe that it's real, because you're telling someone, hey, there's something in you. You don't know that it's there, but somehow it's able to drive your decisions and actions and understandings at time, right? And that's relatively a difficult concept to come to terms with, because it does something to us as humans. It kind of arouses what we know as cognitive dissonance. And what that is, if you remember, is when we find that our intentions and our actions don't line up. They're not in sync. And when we're in that dissonance, then it does some things, but as humans, it makes us uncomfortable, right? And so we need to do what we need to do to get out of that discomfort. So one way of facing this, and we're seeing this a lot now in the news and in politics, is just to say, hey, implicit bias isn't a thing. My intentions and my actions always line up. So if we're talking about it, you're telling me I'm this, or you're telling me I'm that, right? That's one way to face it. And unfortunately, there's a big subset of the population that are deciding to face it that way. The way that I hope we all can face it, the challenge that I have for us all, is to say, okay, let's say that you're right. let's say that implicit bias is real and that my intentions and my actions don't always line up. What can I do to better reconcile those, right? And the answer to that is trying to get an understanding of where it comes from, trying to get an understanding of how it impacts society, and then ultimately trying to get an understanding of how we can mitigate it. So that's the journey that I think we all should take. A couple other bullet points, and this is, I think, a rather important slide, because there's some other things we need to address. What else do we know, right? And it's always important for me to say and recognize the discomfort that these conversations come with, right? And as I talked with you all this morning, a good amount of people on here. I know for some of you, even on Zoom, right? It's not easy to have these conversations or even sit through these conversations. And the analogy that I have comes from a cartoon that I saw where it has, cartoon hands lifting back a rug, and under the rug are the plights of society, poverty and crime and those sorts of things. And there's a big broom and it's just sweeping all of that under the rug, right? And I think of how we faced these situations, these issues, these conversations for up to this point by doing just that, sweeping them under the rug. But I think today and modern day today, we're doing a much better job of peeling the rug back and actually starting to address the issues that lie beneath the rug, right? And so anytime you make a decision, especially at 7 o'clock on a Tuesday morning, to sit in on these difficult conversations, whether you realize it or not, you are making an intentional effort to peel back the rug. And I think that is worth and deserves acknowledgement. So thank you for being willing to do that. One of the other things I want to say is it's not just about race. We're going to talk about race quite a bit, more than any other thing this morning, but there are a lot of groups in our society that are at a disadvantage because of our collective biases, and it's important to try to acknowledge and address as many of those groups as possible. We can't address them all in 45 minutes, obviously, but we're going to talk more than just about race. And ultimately, the most important bullet point to me is this one, right? And I wish people could grasp this, because I think this would take care of all the issues that we're seeing in our community here in Oklahoma and other places as well, is the fact that implicit bias is not the same thing as explicit racism, explicit sexism, ageism, other forms of discrimination or bigotry. It's just not. It is inherently different. And this is the key for me. This is why I feel comfortable saying we don't need to feel ashamed or guilty about it, because our intentions in this case do matter, right? What I also need to say is that although implicit bias is inherently different from these things, the impact of implicit bias, in my opinion, is probably greater than these things today in 2022. And so that's why this conversation is critical, because ultimately for us, it is impacting the care that we provide for our patients, myself included, and it is worsening health disparities. And so these are conversations that need to continue, because we can do something about it, right? And so that's why we're here this morning. All right, so man, I know it's early, but I need your help with this activity here. And before we do that, the best way to approach it is to have you kind of clear your mind. So try to have a blank slate of a mind. And what I'm going to do is I'm going to show you some imagery. And with each image, I'll maybe have a question or two. And I want you to pay particular attention to the very first thoughts and ideas that come to your head when you see those pictures. Okay, so that's the easy part. The more difficult part is being willing to, just jot it down in the chat box. So hopefully you're willing to do that, because if you're not, then this is not going to work. So I'm hoping for your help here. So and the first one is going to be real simple. Just humor me. So here's the first picture here. So my question for you is, what's going on here in this picture? I know it's simple, but just humor me. It's a long CME. information here. There we go, Dr. Bray. Yeah, we've got a lady running. We got somebody who's relieving stress. Exercise, exactly, right? And you knew it exactly as soon as you saw it, right? Even before I asked the question, right? Yes, thank y'all. So tell me this. How did you know that this is a lady running as soon as you saw this picture? How did you know? Because you knew it immediately. Yeah, so we've got someone who's postured in a way that we recognize as running, right? Past experiences, right? You've done it before. The way she's dressed, the environment, and what is all of that? You're absolutely right. And you didn't have to consciously connect those dots. It happened automatically, right? This is all based in our past experiences. Absolutely, Dr. Bray. So it's pattern recognition. That's all it is, right? And so you knew it in a split second, right? Wonderful. So what we're going to do now is we are going to change the location. All right. I don't have Photoshop skills, so I need your imagination. So this, I imagine this to be a home in Philbrook area, right? It's just random internet mansion that I Googled, but we can all imagine a home like this. We can imagine what a neighborhood that has homes like this may look like, right? So now, we're gonna have our lady now running along in this neighborhood. And the question that I have for you is, if you had to guess, if you had to just say, what does she do? What is she into? What is her life like? What are the thoughts that come to your head when you see her jogging in this neighborhood? Who is she? Yeah, so Faiz, the almost without fail, the first comment generally, and I've literally done this 120 plus times probably at this point, is something that gets at the point that she doesn't look out of place, right? She looks to belong in this neighborhood. We don't question her existence in this neighborhood, right? She may be a career mom, so we may see something, someone who lives in a neighborhood like this looks like this, someone who's balancing career and motherhood. She's a mom, right? Jennifer Calloway says she's got money. Chris McNeil says she's maybe an accountant. Any other thoughts that come to mind? She feels safe. That comes up a lot, right? She's not having to look over her shoulder in this neighborhood, maybe for multiple reasons. One, because the neighborhood's safe and she doesn't look out of place in this neighborhood, right? And many of us can understand what the other side would maybe be like. You all are being really gentle this morning. I think what I generally hear as who is this lady, what she may be, one of the first things that generally comes up is she may be someone who stays at home to take care of the children, and that's based in a well-rooted association that if the mom stays at home and tends to the family, right? Even in 2022, and that's obviously not necessarily the case, that association still persists in our communities, right? My favorite of all time, and believe it or not, it came in two separate incidences. Two people made comments that she looks like a lady that loves brunch. And I always chuckle when I kind of recap that, because you can't exactly say why it makes sense, but for some of us in our associations, it makes perfect sense. Right. So great. So now what we're going to do, if you could probably imagine, is we're going to change the character. All right, we got Homeboy here. Homeboy is running along in this neighborhood. Right. So now, when you see this character, this gentleman running along in this neighborhood, what comes to your mind? Who is he? What is he doing? What is he into? Right, Cassie. Yeah, Allison. Yeah, as soon as you see him, for many of us, not all of us, but for many of us, he looks out of place. We don't typically associate someone who looks like this, who's dressed in this way, as belonging in this neighborhood. right? Based on our past experiences. We don't know anything about this guy, right? But those associations come through pretty quickly, right? It's pattern recognition, right? It's based on our past experiences. We often do, almost every time we also get the comment about he may be the son who hasn't quite reached his potential yet, right? So he actually does live in that neighborhood. But we also get the comments about maybe he's up to no good, right? Is crime or drugs involved in the reason why he is in this neighborhood, right? So great, I appreciate all of the engagement in this because this is important. The reason why this is important is to call to all of our attentions that this is really easy thing to do, right? A couple pictures, a couple questions, and all of this information starts flowing, right? Think about now how often we do this in our real lives, how often we do this when we maybe even have less information than I provided for you all this morning, right? When we're passing someone in the hospital or out in the community, or we just briefly meet a patient or a patient's family member, how we are putting together our past experiences and mental shortcuts and coming up with these conclusions, right? When we don't necessarily have enough information to come to those conclusions as firm as we arrive, right? So keep this in mind. The whole point of this is to raise our awareness of how often we do these things. Great. So the reason why we are able to do this so easily is this. It's that bias, implicit bias is based in the concept of mental association or mental glue. And when we have mental association, when there is association between two ideas or two tasks, it allows the decisions or that task to be made with less effort, right? We see that guy dressed like that in a neighborhood like that. We don't associate that, or we associate him being there for a negative reason, right? And then we can come to a conclusion really quickly, right? When there is no mental association, there is no mental glue, it actually requires more mental effort, right? If I were to tell you, well, actually, he's a neurosurgeon. Think about the mental effort it would take for you to reconcile those things, right? It just takes more work, right? And we have recognized this in a lot of ways. More formally, we've recognized it in something that's called the implicit association test, which we won't do this morning. We just don't have enough time. But what the implicit association test is able to do is able to recognize the associations that we have based on how quickly or how slowly we fill out an activity, an exercise. And even though those associations may be implicit, we may not know that they're there. The implicit association test can uncover them for us. And it's a really important and critical exercise for us to get comfortable taking part of. And I'll make sure to leave you with the website to take some of those on your own time. The coolest technology that I think I've ever kind of read about in implicit bias is this here, and it's called functional MRI. And many of you may have heard of functional MRI. You've all heard of a traditional MRI, in which a traditional MRI looks at the structure of, in this case, a brain, right? See that image on the left? It looks at the physical structure of a body part. Well, functional MRI actually looks at the physiologic and chemical activity of the brain. And it does this by detecting increases in oxygen and increases in blood flow. And because we know, hey, when we're using a certain part of our brain, guess what? It needs more oxygen, so it gets more blood flow, right? We can actually see what parts of the brain are working in an individual when we look at their brains using functional MRI. And if we take that a step further, now that we know essentially what every part of the brain is responsible for, we can actually tell what someone is thinking or what someone is feeling using functional MRI, even if they are unaware of those thoughts or emotions. So you can imagine it to be a really, really important technology in the study of implicit bias, and it is. And so there are some studies that I think are worth touching on that use functional MRI in the context of implicit bias. One of those studies has to do with fear, and we've all heard of the amygdala, right? The part of the brain that triggers fight, flight, or fight, right? Fight or flight. And in one study, they took a group of individuals, they put them in a functional MRI machine, and they exposed them to imagery that is humans are innately scared of, right? Pictures of snakes, pictures of spiders, those things that some of us, many of us, most of us have a visceral reaction to, a fear reaction, a visceral fear reaction. And they looked at their brains and they noticed, hey, you know, this individual, that individual, almost all of them, their amygdala were activating, understandably, right? Because they were fearful, right? They then exposed these individuals to things that should not have invoked a fear response, and different pictures, different things, right? And those pictures oftentimes didn't do anything in terms of amygdala activation, but a pattern did stand out. And that pattern was when many of these individuals were shown pictures of young Black males, there was a amygdala response that was greater than when individuals were shown pictures of snakes and spiders and other scary things. And if you think about that in the context of officer-involved shootings, you can maybe understand how implicit bias contributes to some of those tragedies. Right? Sorry, we got an annotator on here. I'm trying to clear that. There we go. Another study had to do with members of the LGBTQ plus community and how they are interacted with other people in the community. And they took people who had an implicit association test result that showed a bias towards same-sex couples. And they put them in a functional MRI machine, and they exposed them to things that humans are generally disgusted by, really gross imagery or really foul smells. And they looked at the part of the brain known as the insula and found that, whoa, when they were exposed to these things, not surprisingly, the insula was activating, right? Because they were disgusted. And then they took these individuals and they exposed them to other things, pictures of things that should not necessarily have invoked an insular response. And what they found is when they were exposed to very appropriate displays of affection by same-sex couples, some of these individuals had an insular response. Literally, that was the same response they had when they smelled rotten garbage, literally. And then we think about empathy and how empathy, depending on the context, can be very different, right? And from an implicit bias standpoint, there have been a lot of functional MRI studies that show that empathy is different depending on the race of the individual experiencing that empathy and the race of the individual who may be having something traumatic or troubling or painful happen to them. Lots of studies out there, even very trivial group membership ties can impact empathy, like sports fanship. There have been studies that have shown that depending on what team you root for, if you see someone experiencing pain who roots for another team, the empathy response can be lessened because of that very trivial group membership tie. And so we know that even though we don't always recognize these emotions, they are impacted in a lot of important ways. And so if we think about some of these things that I've just mentioned in the patient care context, it's not hard to imagine how these emotions, when tied to bias, can impact the way we care for our patients. So I think a really important question is where do these biases come from, right? And if I'm going to make this argument that we have to continue to destigmatize what it means to have implicit bias, I want to make these arguments that having these biases is not anything we need to feel ashamed or guilty of, well, I better make a case that there's nothing we can do about developing these implicit biases that we have. And so that's the case that I'm making right now, by telling you where these biases come from. Well, first of all, the most important place is it's a product of the way our brains work. We know that our brains are literally 3-pound computers. Our brains have the processing power of, maybe an old school Nintendo, but a computer nonetheless, right? And if you think about all the information and data that's coming into our person at every given moment, if we had to attend to every piece of information consciously, there is no way we could function, right? So fortunately, our brains have the ability to process most of this information subconsciously, right? And it frees up our conscious brain to attend to the things that need our conscious attention, right? This is why we've been so successful as a species. No other species can do things we can do in terms of processing information, right? But because our subconscious brain has to rely, again, on mental shortcuts and pattern recognition and has to connect the dots and fill in the blanks, there are going to be times where the brain thinks, yes, I have enough information to make this determination. I have enough information to come to this conclusion. And we're doing that so much that there are going to be times where we just don't have enough information to come to that conclusion. And that can result in biased decision making. That's just kind of what comes with the territory, right? It maybe doesn't happen a lot relative to all the information that's coming in, but because it's so much information, it's happening enough, right? And it can, again, result in some biased decisions. A big portion of the biases that we have come from our past experiences, right? The people that we've met in the past, the situations we've been in, right? Those experiences that we have experienced. And if those experiences were rooted in very strong emotions, we really, really hold on to them, right? More so than others, right? But our brains aren't so good at separating true lived experiences that we actually lived ourselves from experiences that we've gathered secondhand from others' stories, right? Somebody else's experiences, or what we've been exposed to in the media, whether it be the news media or in television or in movies. Right? And we know the news media is a big perpetrator of the biases that we have. We know that the news media has been found time and time again to be more likely to show the mugshot of a Black or brown suspect, but withhold a mugshot of a white suspect. We know the news media time and time again has been shown to represent a physician or an engineer or an architect or a scientist as a man than they are a woman, well out of proportion to how it actually breaks down in society. We know that shows like Cops and Live PD have been found time and time again to overrepresent crimes committed by Black and brown people than white people, out of proportion to how many crimes Black and brown people are actually committing in those communities, right? And so over time, you can see how this can impact our associations of who are the doctors in our society, who are the scientists, the engineers, the architects in our society, versus who are the criminals in our society, right? And to take it a step further, we also know that law enforcement individuals are overrepresented as white men. So again, then who are the saviors in our society? Who are the heroes in our society, right? And over time, those things add up, right? And they shape the associations that we have. And then ultimately, a really important question is, well, okay, at some point, was there a survival benefit to being wary or vigilant or hypervigilant around others, right? Fair question, right? And the answer is probably yeah, right? If we go back tens and tens of thousands of years, prehistoric man, yeah, there probably was a survival benefit to seeing another clan and being like, hey, I need to stay away from that group. I need to be ready to fight to save my life or my family's life if I'm around that group, right? If you fast forward to today, those benefits are probably long gone, but we still may be left with some of those instincts. And so these are a few of the situations in which the biases that we all have developed, right? It's an uphill battle, to say the least, right? And so if we were to ask ourselves, hey, is there a way that we can sort out biases that we picked up through our lived experience from biases that we came into this world with? Well, probably the best way to do that is to look into our babies, our young children. We have a 9-month-old daughter, and you know, she doesn't really have a lived experience. So some of the biases that she may show, we could maybe assume that she came into this world with that, right? And there's a group out of Yale. Again, if we have more time, I'd share a video. But if you just happen to YouTube implicit bias 60 minutes, you can see like a 3.5-minute clip of the Yale Baby Lab, which is the research group out of Yale that researches bias in babies. And it's fascinating research. And ultimately what they have discovered is that even children as young as a few months old have the propensity to favor themselves over others, or favor things that remind them of themselves over others. And so undoubtedly, we do come into this world with some of these biases as well. And a lot of it also just boils down to this: it's group membership, right? And it's super contextual, right? There are times where it may not really matter in other situations or other contexts, but in the current context, being in a similar group may result in us treating someone better, right? Not being in a similar group may result in us treating someone worse, right? And ultimately, it boils down to this, right? When we find that we have a shared experience with someone, we're going to be more likely to favor them in certain situations, right? And so if you think of it in a global context, if you zoom out, if there are more people who have a similar shared experience, then they may be at an advantage in society, right? Because of this. And, you know, I wish I had a big scientific explanation for it, but I don't think we need one. I think it's as simple as we like things that remind us of ourselves. I literally think that's all it boils down to. And so when it comes to shared experience, someone has a shared experience similar to ourselves, we may be more likely, we have been shown to be more likely to favor that individual. So now let's talk about the impact. And I think it's important for us to start to think about our own experiences in which we have had our own biases impact how we treat someone, whether it be in healthcare or outside of healthcare. It's important to think about others' biases that may have impacted us. And I really want you, as you go through the day, later this morning, this afternoon, just try to think about times where this has been the case. I could think of a uncountable amount of stories on which my biases have impacted the care that I've provided for others. When my biases has impacted how I've treated someone. I can think of literally as recent as yesterday, when the bias of who a physician is impacted the interaction that I had with a nurse's aide. She could not get around the fact that even though I had a scrubs on, a stethoscope, and a badge that said Dr. Jabraan Pasha, that I was the actual physician who was requesting something of her, right? It happens all the time. And it's important for us to really pay attention to these things so we can realize that, hey, we have these biases too, that they're everywhere. And that allows us to take the steps needed to recognize what our biases are, and then ultimately to help mitigate some of the biases that we have. So we're going to talk about the impacts in the workplace of implicit bias very briefly. We know historically women, people of color as well, have had a disadvantage in the workplace, and we see that manifested in several ways. One of those is who gets job opportunities. And there's a couple studies that show this really striking result in which in these studies, a white man who disclosed a criminal record on his resume was more likely to get a callback for a job interview than a Black man with no criminal record on an otherwise identical resume. We know that today in 2022, women make 80 cents on the dollar when compared to men for doing the same work, hour for hour. about 80 cents on the dollar. Healthcare is no different. It's just as bad in healthcare, specifically in physicians. It is just as bad. We think about what goes on in the criminal justice system, right? Which I would say is the second highest stakes arena, only second probably to healthcare in terms of making life-altering decisions and life or death decisions. We know that Black, Brown, Native people are overrepresented in the criminal justice system. We know that some of that has to do with social issues, social situations, but we also know that a lot of it has to do with just unequal treatment within the criminal justice system. One of the most disturbing statistics that I've ever seen is a statistic that says that Black men who have been convicted of murder are 11 times more likely to receive the death penalty than a white man who's been convicted of murder. And if the victim happened to be a white person, that number climbs close to 22 times more likely to receive the death penalty. They've even had studies that have linked darkness of skin to harshness of sentence. They've even had studies that have linked the more traditionally Black facial features that you have, the harsher of a sentence you receive on average. So the impact in the criminal justice system is very real. In education, lots of data out there, which is why it is so important for us to be teaching our teachers about implicit bias. I'm so proud to be a Tulsa Public Schools alumni that they have decided that this is information that the teachers need to have. We know that there are studies that show that little Black and brown preschoolers and kindergartners are several times more likely to be suspended and expelled from preschool and kindergarten. Studies have shown that teachers grade little girls' math homework more harsher than they do little boys. There's data to show that teachers make less eye contact with little girls than little boys. There's data to show that teachers are less likely to call girls up to the board to answer problems than they are little boys. This information is out there, and if we don't address it, how are we going to be better? How are we going to do better? And we've got healthcare, right? And healthcare is full of biases. And we're going to dig into this a little bit deeper. I think we're good on time. We've got New England Journal, this was years ago, one of the earlier studies on the impact of bias on clinical decisions showed that white men were more likely to be sent for cardiac intervention than women or men of color. Women with obesity are less likely to receive routine screenings despite spending more contact hours with their physicians. Studies have shown that physicians are less likely to provide opioid pain medicine to Black adults and Black children. There was a study in the emergency department that showed that little Black children with broken arms and broken legs were less likely to receive appropriate pain management, opioids, for their broken arms or broken legs than white children. We've known for a while that women have their physical pain undertreated. There's a narrative that women are emotional. And so if a woman is in pain, well, maybe she's wrong and her pain is anxiety. Or maybe she's wrong and her pain is depression. And so they can be over-medicated in certain ways, under-medicated in others. Studies have shown that women are less likely to receive joint replacement therapies. And by the time they do receive their replacements, on average, they're older and their disease is more advanced. And so you can understand how that may set them up for more complications. Black and Hispanic children, less likely to be diagnosed and treated for ADHD, but more likely to be diagnosed with behavioral problems. And think about that if you had two children, right? Let's take the time to think about this. One child who got an appropriate diagnosis for a mental health disorder, put on appropriate medications, and what their trajectory and their potential could be, versus a child who did not get the appropriate diagnosis and was just labeled as a bad apple who has behavioral problems. Think about what their trajectory would be through school. think about the deficit there when you kind of take in this statistic here. It's actually pretty troublesome to think about. Institute of Medicine, this was early 2000s, just did a sweeping review of the care that minorities receive and found that there's disparities across the board. Right? Heart disease, kidney disease, cancer, HIV treatment. They found that minorities receive fewer screenings, less surgical referrals, less initiations on dialysis. They receive fewer organ transplants, but were more likely to receive amputations. And that hasn't changed today. Still an issue today. And the final area that I want to talk about is probably the area that has gotten the most attention, is getting the most research dollars. And I surely hope it's the area that we start to see improvement in. And that has to do with maternal health. And we know that Native American women and Black women are 2 and 3 times more likely to suffer from pregnancy-related deaths, 2 or 3 times. And I can't share that statistic without talking about this woman here, Sharon Irving, who at age 36 had her first child and died days after from pregnancy-related complications. Shortly after birth, she just wasn't feeling well. Follow-up, she told her doctor, something doesn't feel right. I'm breathing very well. I feel like I'm swelling. She was sent home, was told everything's okay. She went again. Symptoms are worsening. I'm having more trouble breathing. I'm having more swelling. Something is wrong. She was sent home, was told everything was okay. She went back a third time. Something is wrong. She was sent home and was told everything was okay. 3 hours later, after visiting her doctor, she cardiac arrested at home and died. She literally left this world unheard. And what it makes me think of is, first of all, it makes me think of my parents. My mother's 70, she'll be 76. And in her lifetime, she's only had 1 Black doctor. I think about my dad, who will be 78 in October, who has never had a Black doctor. And so what I want us to do is just take a minute to think about what it may be like to live your whole life and never have a physician that looks like you. And you may say, well, why is that a big deal? That's a reasonable response to that, especially if you've had plenty of doctors that look like you, right? But if you've never had one, you get it, right? Because people of color often feel unheard in healthcare. And studies support that. Studies show that non-Black physicians spend less time with their Black patients. Studies show that non-Black physicians spend less time listening to their Black patients. Studies have shown that non-Black physicians spend more time talking during encounters with their Black patients. And that's just because of implicit bias. It's not intentional. And so there's 2 solutions here. One is helping us all of us understand how to better take care of different cultures and diverse patient populations through cultural humility training, through implicit bias training. But the upstream solution is bringing more underrepresented doctors into our communities, right? Getting more underrepresented students into medical school, right? That's the ultimate upstream solution. So going back to Sharon Irving, I think it's important to recognize that her story is not unique. It's not unique at all. This happens far too often. But what makes her story particularly powerful is actually who she was. Because Dr. Sharon Irving was a brilliant woman. She graduated high school at age 16. She had multiple master's degrees. She had multiple PhDs. She was a public health officer. She had a master's in public health from Johns Hopkins. She worked at the CDC as an expert on racial health disparities. And with all her expertise and all her education, she was unable to advocate enough for herself to save her own life. She literally left this world unheard. And if she was unable to do that, who else has a chance? Who else has a chance? So this is the lowest part of this presentation because it's tough, right? It's tough to talk about these things. It is, and the tone, especially when we do this in person, the tone at this point in the presentation is at its worst, right? But it's important. It's important to lean into that, how we feel when hearing about Dr. Irving and her life being lost far too soon. It's important to lean into these statistics that we just talked about. They're troublesome, but they're important, right? But the good thing is we can start to bring the tone up a bit because we can talk about what we can do about it, right? There are things that we know are beneficial in terms of combating the biases we have. And I use this term combating because it's a fight. I don't use the term eliminate because I don't think we can eliminate our biases totally, but we can work towards being better. Right? So there's some things as we wrap up that we know can be helpful. And the first is what we, again, want to do is destigmatize what it means to have implicit biases. Separate the idea of implicit bias from feelings and emotions of guilt, shame, and badness, if you will, because we don't need to feel any of that because it's a part of the human experience. It's a part of the way our brains work as to why we have these biases. And once we don't feel bad about it, it surely makes it easier to face it. It is what it is. What can we do to be better? It allows us to acknowledge, hey, we too have implicit bias. We're no different. We all have it. And once we've acknowledged that, we then have this ability to recognize biased thoughts when they bubble into our consciousness. It just makes it so much easier. We can pick off those thoughts and start to attach those thoughts to associations. And that's how we start to realize what some of our associations and biases are, right? That's how it works. It's critical. We need to continue to explore awkwardness and discomfort. That's asking ourselves, why do we feel uncomfortable? Why do we feel awkward around people or groups of people, certain groups of people? Is it because they are doing something to make us feel uncomfortable, or is it more about us than it is about them, right? Do they remind us of someone we met in the past, someone we used to know? Do they remind us of a character on a movie or a TV show? Who knows? But it's important to explore that, to try to answer those questions. Considering the opposite is really important, especially when you're making critical decisions, whether it's treatment decisions or decisions to withdraw care and go comfort measures, hiring decisions, firing decisions. All of those critical decisions need to be countered with just giving yourself the grace that you could be wrong and consider it from the opposite side, right? What is that going to hurt? Most of the time you're going to find, no, my first decision was probably the right one, but there will be times, I promise you, where if you look at it from the other perspective, you may say, oh, wait a minute, right? I was looking at that the wrong way. I interpreted that the wrong way, right? That's an important part of this process. Exposure to exemplars and counter stereotypes. This is probably, in my opinion, and maybe the research supports this as well, maybe the most important thing we can do to overcome our biases. And that is just simply being around all different kinds of good quality people from different backgrounds. And so one thing I want you all to do when you have some time, it's a really simple exercise. It's called the trusted 10. What you do is you take a sheet of paper and you number 1 through 10 on the left, down the left-hand side. And you think about up to 10 people that you would call your closest friends, not family members, not significant others, your closest friends, all right? And you list them up to 10. And then next to each name, you list their age, you list their race, you list their gender, you list their sexual orientation, you list their religion. You fill it out and you just simply zoom out. And you take note of who you don't spend any time with, people you don't get to know, right? And if there's certain types of people that are missing from your circle, then you're left to the associations that society puts out about what those individuals may be like, right? And so you can imagine how broadening your circle, being around good quality people from different backgrounds can actually be one of the biggest things we can do to eliminate the biases, work towards eliminating the biases that we have. You know, this is something to consider, you know, blinding decision processes. We think about hiring, we know that learning about a patient's age or gender or race can be barriers to fair treatment, right? But we also know if we're intentionally trying to improve diversity, we need to know those things too, right? And so that's why it just says, considering this process can be helpful. Reviewing undesired outcomes, we all know, the whole goal of like M&Ms, morbidity and mortality conferences, reviewing bad health outcomes. We do that all the time. We generally just review the medical details, the medical data, but building in some time to consider did biases on the behalf of the healthcare team lead to those negative outcomes. It's something to consider. I wish we could just say, hey, because it's the right thing to do, having more diverse and inclusive environments is gonna happen, right? It just doesn't work like that. We've known it's the right thing to do, but we're still lagging behind where we should be in a lot of ways, right? And so we have to make cases for diversity and inclusion, and we have cases for it. We have a business case for more diverse and inclusive workplaces, and that business case is simply diverse and inclusive businesses make more money. They are literally more profitable, and that has been proven time and time again in multiple research studies. All right, so there's a business case for it. There's also a healthcare case for it, because we know that diverse healthcare teams take better care of diverse patient population. It's simple, right? So there's a healthcare case for it, and it's sometimes just a matter of being reminded of this to help move the meter, if you will. And if we're going to put 1 through 8 together, well, 9 is what we would be able to do, right? This is what we're trying to do. We're trying to, when we interact with someone, interact with them as the individual person they are, as opposed to being part of a smaller or larger group. Trying to make decisions about them as the individual person they are, as opposed to being part of a smaller or larger group, right? But somehow also taking into account the unique experiences that they bring, right? It's difficult, and to be honest, it's completely unachievable to do this every single time. But it doesn't mean we shouldn't work towards this, right? So this is our ultimate goal. And with that, I'll wrap up. Just a couple of references here and recommendations more than anything else. Blind Spot: Hidden Biases of Good People is the whole reason that I'm in front of you. If I hadn't read that book, I would not have been doing this work. Everyday Bias is also a good read. In terms of difficult conversations, I have a podcast, and that's what the podcast is about. It's about having difficult conversations. And so we have people on, and we may talk about implicit bias, we may talk about health disparities, we may talk about criminal justice things. It's I think a very useful podcast, and just learning to have these difficult conversations. So if you have any interest, you can find it on Apple Podcasts or Spotify. It's called Lean In with Jabraan Pasha. And if you're in the Twitter world, I'm at Jabraan Pasha. And finally, thank you all. I recommend you take some time to dig into these implicit association tests. Implicit.harvard.edu. It's called Project Implicit, and give some time to checking these out. So turn it over back to Brenda for any questions or comments that you may have in the 2 minutes that we have left.
Excellent presentation, Dr. Pasha. Thank you so much for giving us a well-rounded view of implicit bias. And that being said, I'm going to turn over to Dr. Alexopoulos, who is pretty much over grand rounds, and see if she'd like to share some words with you. Thank you so much.
Thanks for having me.
Thank you, Dr. Pasha. I really appreciate you being able to join us and really have this discussion around a topic that is difficult for some. And so the manner in which you presented it was outstanding, and we sure hope to have you back soon if you're able to join us again.
Thank you very much. It's always a pleasure to collaborate with you all. You're just down the road. I hope we can continue to do more of these things.
Would love it. Thank you so much.
All right. Have a good day, everybody.
Bye for now.
Thank you, everyone.